Hi, this is Peter Boland, and welcome back to the second episode on maternal health. This is more health, less healthcare. Today, I want to talk about something that most people don't think of as a tax, but it functions exactly like one. It's the hidden tax on motherhood. When we hear the word tax, we usually picture something visible, like a line on a paycheck or a sales tax at the store, something that's documented, itemized, and official. But there's another kind of tax that doesn't show up on a receipt, and that's what families pay when maternal health system fails them. And here's the thing, we're all paying it, whether we realize it or not. We pay it when a pregnancy complication goes untreated until it becomes an emergency. We pay it when someone can't get to prenatal care because it's too far away, too expensive, or too complicated to navigate. We we pay it when a baby, starts life in crisis because the system didn't invest early enough in the health of the person carrying them. And those costs don't just disappear. They show up later in hospital bills and lost wages and long-term health issues and in the stability of entire communities. And this isn't random either, because the burden doesn't fall evenly, it follows patterns, patterns shaped by income, race, geography, and access to care. If you have fewer resources, fewer options, and less flexibility, every gap in the system becomes more dangerous and more expensive. And that's why maternal health isn't just a medical issue, it's an economic issue, it's a workforce issue, it's a community stability issue. And it's a test of whether we're willing to invest early or just pay more later. Well, let's make this more concrete. In 2020, the total the cost of adverse pregnancy outcomes in the United States was estimated at $165 billion. And that's nearly 1% of the entire economy. That number includes everything: medical care, lost wages, long-term economic impact, and the cost of lives cut short. This is not a small problem hiding in the margins. It's built-in drain. You can see it clearly in hospital costs, because a healthy full-time birth might cost around, $6,000 to $7,000. But when things go wrong, the costs escalate quickly. And a moderately preterm birth can cost tens of thousands. Low birth weight can push past $100,000. And extremely preterm births can exceed $200,000 per case. And these aren't rare one-time events either. They happen over and over again. And they quietly drive healthcare spending in ways people don't ever see. But the hidden tax isn't just on hospital bills. It shows up in everyday life. For example, in 2020, families spent billions of dollars on non-medical costs just to give birth. Things like travel, gas, hotels, childcare, and time off work. Now imagine having to leave your home county just to deliver a baby. Now add the cost of gas, maybe a hotel stay, maybe shifts at work, figuring out who's watching the other kids at home. None of this shows up on a medical bill, but it's real money coming out of real households. And then there's the cost we can't fully measure. When a mother or infant dies, we often talk about the tragedy, and it is a tragedy. But there's also a long-term economic impact: years of life lost, years of work, caregiving, and community contribution that never happened. The researchers estimate that maternal health deaths alone account for well over 100,000 years of potential life loss in just a few years. Those are just not numbers, they're birthdays and careers and relationships and communities ties that never get to unfold. That's a loss for everyone. And then there's another layer to this, what you might call community drag. When maternity services disappear from a region, everything shifts. Travel times go up, risk increases, and families start to ask a simple question. Is this a place where we can safely build a life together? Employers notice too, and so do young families deciding whether to stay or to leave. And over time, the absence of safe childbirth becomes a signal that a community itself is being left behind. So who's paying this hidden tax? The short answer is everyone, but not equally. Families pay through medical debt, lost income, and the stress of navigating complicated pregnancies or long NICU stays. Employers pay through absenteeism, turnovers, and reduced productivity when workers are dealing with high-risk pregnancies or recovering from difficult births. States and health systems pay through higher Medicaid costs and the long-term ripple effects on workforce participation and economic growth. But the steeper costs fall on those with the least margin. Now in 2024, the maternal mortality rate in the US was 17.9 deaths per 1,000 live births. Again, 17.9 deaths. For Black women, it was 44.8. For white women, 14.2. For Hispanic women, 12.1. That gap isn't subtle. It's not explainable by individual choices alone. It reflects differences in access, treatment, environment, and systemic bias. If we saw a gap like that in any other sector, we wouldn't call it a statistic, we'd call it a crisis. But in maternal health, it remains a statistic. And more importantly, these outcomes aren't inevitable. They're just the result of decisions. Decisions about how we design healthcare networks, decisions about what gets reimbursed and what doesn't, decisions about whether preventive care is prioritized, or whether we wait until things go wrong and then pay a lot more to fix them. Right now, the system is tilted towards reaction instead of prevention. We pay generously for intensive care once a crisis happens, but we hesitate to fund the things that can prevent this crisis in the first place, whether it be transportation, housing support, mental health care, blood pressure monitoring, or culturally responsive care. We reward rescue more than prevention, procedures more than continuity, and fragmentation of care more than building trust. And here's the important part, that can change. Even using conservative estimates, if we prevented just half of avoidable maternal and infant complications, things like preterm births and low birth weight, we could save somewhere between $75 and $80 billion every year. That is an enormous, enormous sum. $80 billion a year. We know some of the solutions. And for example, in California, a statewide initiative focused on maternal quality care helped cut maternal mortality by more than half over a decade. They did it with relatively straightforward strategies: standardized safety protocols, better data tracking, coordination across hospitals, so that best practices became the norm. There's also strong evidence behind approaches like home visiting, group prenatal care, doula support, and community health worker programs. When these are well-funded and connected to clinical care, they improve outcomes and reduce costs. So, this isn't a mystery. It's a matter of priorities. And that brings us to leadership, because ultimately, this hidden tax persists because of what organizations choose to measure, choose to fund, and choose to act on. For hospital leaders, this means treating maternity care as essential, not optional. It means implementing proven safety protocols and tracking outcomes, including disparities by race and location. And for health plans, it means designing benefits that actually support prevention, covering things like prenatal care, mental health, doulas, postpartum support in a meaningful way. And for employers, it means creating conditions where workers can attend medical appointments without risking their jobs or income, and holding plans accountable for outcomes. Now, across all these groups, it means putting maternal health where it belongs, on executive dashboards, in boardroom discussions, and in performance metrics that can be tracked. And because if it's not being measured and discussed at that level, it's not truly a priority. So at the end of the day, the hidden tax on motherhood is just not about healthcare. It's about what we value as a society, as a community. And right now, we're effectively sending bills to families, especially those with the fewest resources, and calling it inevitable. But it's not inevitable. We can design a system where having a child doesn't come with an invisible surcharge on health, income, and stability. The costs are already here. The bill's already being paid. The real question is whether we keep ignoring it or finally deciding to do something concrete about it. So in the next episode, I want to look at where policy fits into all this, because policy is basically where values turn into rules, and rules govern the system. So again, this is Peter Rowland. Tune in next time for the next episode on maternal health. This is More Health, Less Healthcare. Thanks.